Okay, so we're here today with Rachel Young. Now, I know Rachel Young. Rachel's a friend of mine. She works at the university that I trained at. Hi, Rachel.
Oh, good morning. Hello there.
Thanks for talking to us today. Um, so before we start, maybe you could just introduce yourself to people, just to let them know, for people that don't know you, to let them know a little bit about who you are and what you do.
Yeah, well, my name's Rachel Young, and I qualified as a physiotherapist in 1995, and worked within the acute neurological setting for the first kind of 8 to 10 years of my career. So did quite a lot of acute stroke rehabilitation, but also more recently worked on the neurosurgical unit. So that included management of ventilated patients following neurological changes, and also their very early rehabilitation. When I moved into the university, I continued to do respiratory work for a while, but I'm not currently working within the NHS and haven't done for about 7 years now, I don't think. But what I also have done more recently is some private neuro work, so working with patients who are further down the line in terms of their rehabilitation or living with a long-term condition. So I suppose I've had the benefit of working in ITU with very acute patients, but also with patients who are community-based and accessing sort of longer term outpatient services as well. I think a growing area of interest for me is in exercise prescription. I think that wasn't something that I particularly thought about back in my early clinical days. So I never really considered the aerobic condition of the patients I was seeing. I never really considered the muscles in terms of their strength and their endurance performance either. So I think it's been quite interesting to look back on practice, particularly looking at evidence which is coming out now related to exercise prescription in neurology, and piecing together, I think the broad spectrum of skills that we have as neurological physiotherapists, and using both those handling skills, but our knowledge and understanding of physiology to really maximise long-term outcomes, not just in terms of movement and function, but also particularly aerobic condition, and trying to reduce the risks associated with a sedentary lifestyle, which so many of our neurological patients face. So that's where I'm at the moment,
Yeah,
really.
I
Yeah.
think that the exercise prescription, how we've moved into that sort of arena for people outside of the musculoskeletal realm is really interesting. Um, we'll come back to that, but just can you just so you've been working in neurology for for a while, and can you how has that sort of neurological physiotherapy, how has it evolved over the last sort of 20 years or so? How has our practice changed? Um,
I think certainly the teams that I've worked with within the UK, certainly back in the 90s, so when I was practicing probably between about 95 up until 2000, it was very much a bow bath focused approach to rehabilitation. So the emphasis was upon normal movement, and certainly I remember we would often discourage patients from moving unless they were moving in a normal way. So patients who were able to walk were often discouraged from walking unless the gait pattern was something quite close to normal, or it was felt that they'd absolutely reached their potential and that was as good as it was going to get. And that was, very much the philosophy that was, very visible, I think, in practice back in the 90s. And certainly within the UK, we were also aware of the car and shepherd approach, or also known as the motor relearning approach. And I think they were almost regarded as opponents to the Bobath approach, that we had the Bobath therapists here and the car and shepherd or motor relearning therapists there, and there was almost some sort of competition between them. I think when I did my master's, which was about 5 years after I qualified, we really started to unravel and unpeel some of those approaches. And actually, the two approaches, I believe, are probably far more similar than some people would have possibly assumed. So I think with motor relearning, there's a bigger emphasis upon verbal instruction, there's a bigger emphasis upon repeated movements, but that's not to say that a Bobath therapist wouldn't use those skills as well. And I think, the two approaches are merging. I think there's a lot more sort of collaboration, a lot more sort of camaraderie as neurological physiotherapists now, in terms of really working to maximise potential. And I believe there's some patients who will respond very well to a traditional Bobath approach. There's some patients for whom they don't like being handled, they don't respond particularly well to that, they probably don't really have the potential to particularly normalise their movement. And in those situations, different approaches and the ability to be flexible and try different things is essential. And I think certainly all of the Bobath tutors that I've met over the years would agree with that. I did the 3-week Bobath course, and it was led by Mary Lynch. And basically, she said, if it's working, just call it Bobath. So I think there's a lot more fluidity, particularly over the last 20 years, about how we might brand or package the approaches that we use in rehab. And I think there's also a lot of evidence which suggests that it's important that whatever we're doing with a patient, we continue to change it, even if it's working, that we change it, we progress it, we try different approaches, because I think neuroplastic change is stimulated by change. So I think to have a broad spectrum of skills in our toolkit as neurological physiotherapists is really important. I think certainly from what I gather of what I see of NHS practice at the moment, particularly in acute stroke, probably more than the other conditions, is a very early priority in terms of enabling people to go back home or out into intermediate care settings, which I think there's a lot of positives about that. I think the very acute hospital setting isn't an ideal place for rehab to take place. But I do think that probably a lot of those physiotherapists working in very acute rehab spend a lot of time enabling patients to be safe within their home environments. And that will be about sort of supporting function transfers using equipment and techniques that will support that. So again, I think probably compared to the experience that I was having 20 years ago in a stroke unit, that job's very different now, that role's very different. I think whether that's a good thing or a bad thing, it's out there for debate, isn't it? I'm sure there's a lot of strong feelings out there about how aspects of that side of practice have changed. And I think also within the UK, we're seeing a much growing, much bigger market for private services in neurological rehab, that a lot of people are accessing independent or private neuro services, either to progress their rehabilitation following the onset of something like a stroke or a head injury, or to manage a long-term condition such as multiple sclerosis or Parkinson's as well.
So it sounds like that the way that we've progressed is that there's more of an approach to including exercise therapy and perhaps patient-led therapy as well, and activity in the management of people with any neurological condition, and also the early getting people back into their homes and social circumstances earlier than perhaps we used to. You mentioned that we need a broad spectrum of skills as a neurological physiotherapist to treat these people. What is that broad spectrum of skills that we need to have? If someone's wanting to, so me, who's got no experience of treating neuro patients, if I wanted to get into treating people with neurological conditions, what would I need to be looking at to improve my knowledge and skills?
I think movement analysis, as in many areas of physiotherapy, is where it starts. So I think to be able to assess somebody in terms of their movement patterns and identify what might be causing inefficiencies in movement is really important. So certainly looking at the Bobath concept now, they moved away from talking about normal movement, and it's much more about efficient movement. And I think when movement is inefficient, it becomes effortful, it potentially triggers pain, and people avoid it. Yeah, and we want people to feel that they can enjoy movement, that they can feel confident and like they've got the energy to move again. So I think being able to analyse movement, analyse what's making a movement inefficient, whether that's, sort of transfers, walking, upper limb activities. I think that's where it starts. And there'll be a lot of different things that might impact the efficiency of movement patterns. So it's definitely musculoskeletal changes. So we need to know our anatomy. We need to know what structures might be tight, what structures might be lengthened and therefore weak. We need to know which muscles are underactive or overactive. I think we need to understand about joint integrity, good joint alignment as well. So, in neurophysio, we can't forget our musculoskeletal anatomy. It should still be central to the way in which we're processing and analysing patients. But I think the other thing is about aerobic condition and neuromuscular condition as well. So, often people are very deconditioned. They will become very breathless very quickly. And again, as soon as we start becoming breathless when aerobic demand is high, because we're deconditioned, it makes movement inefficient as well. So people start using accessory muscles for breathing and adapt their posture to try and sort of maximise their oxygen exchange. And again, it's not enjoyable and it's something that people will avoid doing. And so I think to be able to make some judgment about aerobic condition and how that's impacting the way in which someone moves should be, closer to the forefront of our minds than it probably historically has been. But then I think also to be able to identify muscle tone changes, and it's so difficult, but I think to differentiate between what might be a muscle that's hypertonic, so has got absolutely an element of abnormally increased muscle tone, or simply is it just tight? Yeah. Is it a compensatory strategy? Is it that the muscles working hard, but that's to some extent under voluntary control rather than a more sort of pathological change within the neurological system? And I believe that whilst physios would always still find that challenging, we're probably the profession that is the most skilled at often making those decisions. And again, sort of maybe being prepared to think about pharmacological interventions as well. So whether or not there is an indication for something like baclofen or Botox, if that could help someone to really sort of break down possibly a cycle of unwanted muscle activity. But starting with the assessment, and I think working out what it is about the way in which someone's moving that's making it difficult, making it kind of effortful and inefficient, and therefore something that they avoid doing if at all possible. But then I think obviously communication and understanding what motivates that particular patient, getting to know them and where appropriate, getting to know their families and carers. And I think, understanding what will motivate them in their therapy. And again, I think thinking about who else can support this process really. Neurological changes and neuroplasticity will occur around the clock, and we can't be there. With a lot of services, you might be seeing patients 2 or 3 times a week at the most. So it's again really thinking about what's happening in between therapy sessions. How can we maximise the gains that we might make in 1 hour? How can they be sort of developed in the very long hours where we aren't around? And again, thinking about the use of other professionals, assistant staff, technical instructors, but again, the fitness industry, exercise instructors, and the role that they might have in terms of the longer term support for somebody in terms of improving their condition. So we haven't even talked about techniques yet, really, have we?
That's all right. Let's come on to techniques in a minute. So do we have a position to teach carers and other people, I don't want to say multidisciplinary team, but other carers in society, like you mentioned, the fitness instructors, do we have a position to teach them as well some of our skills to use on the patients to help in the times when we're not with them?
Absolutely, and I think the fitness industry have developed a couple of specific awards. So I think there's a level 4 award in terms of exercise prescription for neurological groups, and there's a couple of big sort of growing bodies within the UK that run exercise classes that are for neurological patients. I think that message is well and truly out there, and I think physio is running quite fast with it. But I think for the fitness instructors, I think it's for them to also develop their skills in terms of movement analysis. And obviously with neurological patients, we're going to see movement patterns which aren't entirely efficient, which aren't what might be described as normal, but where the sort of I suppose the spectrum of acceptable is, and when someone's movement patterns might become unacceptable in terms of risking injury or overuse injuries, musculoskeletal changes that in the long term will be a negative thing for that person as well. So I think it's about sort of recognizing, movement patterns and thinking about how, where where the line for acceptable is, and where the point at which we might stop an activity.
Yeah, and would you teach carers the same sort of thing as well as a physio?
Yeah, and again, I think it would depend upon the remit of that carer and how comfortable they were. I think there's examples. Certainly, I did some interviews recently with service users, and in one case there was a gentleman who'd had neurological changes as a result of spinal surgery. It was very complex, and his wife was his main carer, and she was doing a fantastic job of sort of supporting his weekly exercise program and therapy. So he had kettlebells, he was going to the gym a couple of times a week, he was doing walks around his garden, and it would have been impossible for him to engage with that level of activity without the very active support of his wife, who was also his carer. So I think, as always with those situations, we need to assess each situation as we find it. But in a lot of situations, it's a really positive role for the carer to have. So they might be supporting ADLs, but I think sometimes it's really motivating for them to have an exercise program to support as well. Yeah.
So going back to the broad spectrum of skills, what about techniques that we need to be skilled in?
Yeah. So I think certainly getting musculoskeletal alignment is important. So if joint alignment and the soft tissues around a joint aren't aligned in a way that will give them a good biomechanical starting point, the movement won't go well. It will be inefficient. It will be effortful. It might predispose people to musculoskeletal changes or injury. So I think having the skills to realign a joint. So particularly in neuro, we often see that the glenohumeral joint, the wrist joint, and the knee joints are often not lined up. They're not biomechanically positioned as we would like them to be. So start off with some joint mobilization techniques. The ankle, the subtalar joint are other areas where we often see changes to the alignment. So basically get the bones roughly where they should be, and the soft tissues. So stretch out the weakened soft tissues, try to activate the lengthened weakened muscles. So again, thinking about the ankle and subtalar joint, what we so often see is that the perineal muscles are lengthened and weakened, and we've got quite a lot of tightness often in tibialis posterior, tibialis anterior, the medial belly of gastroc. So we're seeing that the foot's pulled into this position of inversion, which makes weight bearing and balancing really difficult. So if your foot's not properly aligned to the floor because your ankle joint's out of line, then your vestibular responses, your balance responses aren't going to work properly either. So start off with the musculoskeletal handling skills, and that's what, as a profession, we are very good at. They are part of our specialist techniques, which can't easily be replicated by other professional groups. Once you have got a joint in alignment, start to move it, start to perform functions with it, using varying degrees of facilitation. So you might facilitate quite heavily. You might, for example, if you're looking at foot alignment in gait, you might almost make it a passive movement initially, just to give some proprioceptive sense of what that movement should feel like. But it's important that we withdraw from that as well, and enable the patient to start to increasingly activate that pattern of movement for themselves, taking it forwards into function. But also, I think, thinking quite early on about more specific strength work, more specific kind of muscular endurance work, and also cardiovascular stamina that can go with that as well. So starting off with musculoskeletal techniques, we're thinking about techniques in terms of facilitating normal movement, taking that forwards into function, taking that forwards into exercise prescription. But then I think also being aware of the wider toolkit as well. So looking at, for example, if someone would benefit from functional electrical stimulation, whether particularly with people who've got upper limb deficits, whether constraint-induced movement therapy, a period of that might benefit them as well. So being aware of the different approaches that are out there that for certain population groups or diagnostic groups are definitely evidence-based, and making decisions about, in this situation, would it work? So some people will respond really well to CIMT, constraint-induced movement therapy, but it's important that they've got a reasonable amount of movement in the hand. If they've got no movement in the hand, then it's not going to work. It's just going to be a very sort of frustrating, unacceptable therapy intervention for that individual. So I think it's recognising what the sort of indications are for the different techniques that we might use.
So you kind of talked about almost like our neuromusculoskeletal techniques about the joint alignment, how the muscles are working, the muscle balance, and moving that into function. And that seems to be our core skill that we need to have. And these other things like the functional electrical stimulation and the constraint-induced movement therapy, would they be considered adjuncts for specific populations or people, individuals that in which they're indicated? Would that be a fair way of putting it?
Yeah, definitely. So not everyone will respond well to a functional electrical stimulator. Not everyone will respond well to CIMT, but there's a proportion of the neurological population that will. So not every neurophysio needs to have those skills or that equipment, but they should know what the indications for successful use of that strategy might be, and therefore be able to build up the network and the contacts so that they can make a referral if they think that that's something that that particular patient might benefit from. I think we should have an awareness of all the different strategies or interventions which might use. That's not to say that we need to be sort of individually confident with using them all. That'd be quite a big ask, I think,
Yeah, for
of one
sure.
therapist and one service, even in terms of the equipment and resources. But I think what every physio should be is confident about the gym environment, and be confident to take complex patients into a gym to start to interact with the fitness industry, understand what the remit of their roles are, and to be able to identify the activities in a gym which might really support a longer term outcome and a longer term engagement with physical activity. I think it helps to demedicalise the rehabilitation process, and I think it helps people to think about, this isn't just something I'm doing for the next 3 months whilst I'm getting over my stroke. This is maybe something I need to do on a longer term basis. Obviously, someone who's had a stroke, there's probably risk factors in terms of their cardiovascular health. So, promoting physical activity, just like someone who's had, for example, a heart attack, we'd always think about them in terms of their cardiac rehabilitation. That same thinking needs to be pulled over into the stroke population as well.
So
So
let's talk about, because I know you've done so much work in this physical activity, promoting physical activity in neurological conditions and long-term conditions. Let's talk more about this. Where, and it's talked about more and more these days. So with someone that wants to start promoting physical activity in their patient that is an individual with a neurological condition, where do they start? What should they be thinking? And then tell us how we should move through that process with those patients.
yeah, I think knowing your local facilities is really important. So looking outside, possibly you're a community physio working mainly in people's homes. You might be working in intermediate care. You might be working, within the hospital or a private clinic. I think it's knowing what the facilities are within your local communities where your patients live. So being aware of where the accessible gyms might be, being aware of any other kind of accessible facilities that wouldn't overwhelm a patient. And I think also, getting to know your patients and thinking what sort of environment would suit them. So some patients might like somewhere where it's quite noisy with lots of music, lots of like people. They might think that's quite good. Other patients would just not, respond well to that sort of environment. Certainly in Sheffield, we've got a couple of accessible gym facilities, and, sort of getting to know some of the instructors who might be working in those areas as well, and where possible, sort of setting up agreements that you can go in and work together and possibly have a kind of a temporary membership, or something that's subsidized so that the patients can access those services on an acceptable level. Certainly within a regular gym, the machines which I think can be really useful for the neurological patients are the leg press. So that's the one where you put your feet on a platform, and you push the platform away. So it really recruits the quadricep muscles, but also the hip extensors as well. Hip extensors, well, hips remain flexed, so you're not moving the hips into that position of extension, which again I think can be really beneficial for neuro patients, but at least those muscle groups are getting recruited. And it is a closed chain activity as well. So again, if you've got someone who tends to get unwanted tonal changes, particularly around the ankle, they'll probably be inhibited by the presence of the platform because they've got that nice surface. So that's certainly one of my preferred machines within the gym. And again, it helps to strengthen the quads. And again, there's some research that's coming out over the last couple of years which really supports strength training in neurological patients, showing that it has a really positive impact on outcomes for balance and gait, which are often priorities in terms of the goals that those patients will set. Another machine which I really like is the seated abductor. so
Yeah.
so again, you're sort of sat in your chair, so it's fairly supported. Even someone with quite significant mobility restrictions would be able to probably access it. And it really helps people to identify where their abductors are and to recruit them. And again, the feet are supported, so it would hopefully prevent any unwanted distal changes in terms of tone as well. So I would start off with probably those two exercise machines. I think nice to get people if there's a tricep machine as well, because again, the triceps are so hard to access often with neurological patients, to see if they can, particularly if it's bilateral, see if they can get some activity going in the triceps. So, looking at the strength machines, being confident around the resistance machines, and thinking about how they might work for some of the patients that we see in. In terms of free weights, they do require probably a better background of postural control. I think there's a lot of people without neurological changes who still perform really badly with free weights. So I think, first of all, being confident with free weights yourself as a therapist and knowing yourself how to handle a dumbbell or a barbell, and what some of the basic techniques might be, but things like, certainly for higher level patients who are making good progress with the rehabilitation, things like squats, particularly using something like dumbbells, barbells. Again, it's going to, in terms of a patient's self-esteem, self-efficacy, it's going to be really positive. It doesn't feel like medical rehabilitation anymore. It feels like a proper exercise program using proper exercise equipment. I think in physiotherapy, we're always very functional. We're always very good at making do with a tin of beans, a bag of sugar at home. That's all right. But I think particularly, not just our younger patients, all of our patients would probably get more excited about equipment that's purpose built for that type of program. So yes, I think as physios, we should be confident with free weights. We should be thinking about how they might be used with some of our clinical populations. Free weights probably aren't for every neuro patient, but absolutely some could do really quite well with them. And then in terms of the cardiovascular machines, there's a lot of research out there about treadmills, and particularly body weight supported treadmills. A lot of us won't have access to a body weight supported treadmill, and the evidence is probably quite mixed in terms of how effective they are. I quite like the climber, and the cross trainers, the two machines where, again, you've got your feet on a moving platform, but your foot remains on that platform. I think what a lot of neurological patients find difficult with treadmills is the moving base of support that they have to lift the foot away from and then realign it back on again. So some patients do quite well on a treadmill, but I've certainly seen some patients, particularly if they have distal tonal changes, sort of struggle and perform a gait pattern that I don't think is particularly good, really. So again, I think looking at the cross trainer, the climber machines in the gym, really good way of sort of looking at aerobic performance, really good way of improving aerobic condition, and it also can be quantified. So you can say, well, last week you managed 7 minutes at level 2, this week you've managed 8 minutes at level 3. You are getting stronger, your cardiovascular system is getting fitter. And think in terms of the physiology about the adaptations which will be occurring with those activities as well, in terms of capillary networks and changes to muscle structure too. Static bikes are good, and the recumbent bikes, a lot of neurological patients will be able to access those machines quite safely. And again, you can quantify how far they've gone and what sort of cadence they've used as well. So again, I think using goals and using that to motivate patients in terms of their long-term adherence, it's going to be really good. And I think working alongside the gym instructors to make sure that that transition is supported as well.
So those are some really good tips, some really good ideas for using things within the gym setting and sort of with free weights as well, which people can do at home. But what about people that don't have access to any of the equipment? What sort of things should they be thinking about to increase their activity levels?
I think again, it's finding out what people might enjoy as well. You might be sort of turning the clock back 20, 30 years, but what did they enjoy possibly if you've got an older adult? What have they enjoyed in the past? It might be something like dancing, it might be, walking, it might be being outside, it might be gardening. Um, I did some research recently in a local trust, and it wasn't with the neurological population, but it was with people who had long-term musculoskeletal changes. And we found that, a couple of people had historically enjoyed walking, and particularly sort of walking out in the hills. It had stopped happening for various reasons, and then injury had made it seem like even a bigger barrier. But they'd gone through a fitness program, and I think the fitness instructor involved within this project had been very skilled at talking to people and working out what they might enjoy beyond kind of the episode of gym-based care. So I think, looking at people's home environments, things like, sit to stand, it involves, strengthening of the quads, strengthening of the hip extensors. It places a demand upon the trunk muscles, and it is also aerobic. Even a really conditioned person will have a higher heart rate following sit to stand than they would have done when they were just sat down. So, I think it's recognizing, everyday function and helping people to identify what they've achieved. So looking at things like repeated sit to stand. If you're really limited in terms of time, facilities with somebody, then it's a really effective exercise. And again, it's closed chain, and a lot of the evidence about neuro rehab suggests that closed chain strengthening is much more effective than open chain strengthening, where we might struggle more to control unwanted tonal changes.
Yeah, absolutely. Okay, so we're assuming with these patients that they're all safe and that they're able to be outside, outside the hospital environment. Let's say. What about the people
Yeah.
that are more acute? Because it must be relevant in those sorts of acute situations as well. Increasing activity levels. What do we do with those people?
Excuse me a minute. Absolutely, I think. And when I look back on my practice, particularly on neurosurge, that we weren't, even though we were looking at people who possibly been ventilated and had significant respiratory changes, we probably weren't thinking enough about their basic aerobic condition. We were very much focused upon sort of symmetry, recovery of movement, recovery of function. So I think certainly within hospital wards, I would like to see a lot more exercise equipment. So things like a set of dumbbells. They don't really cost very much. They don't take up much room in terms of storage. I would really like to see physiotherapists, on the hospital wards with an aerobic step, with a set of dumbbells, and be much more definite about their exercise prescription on the ward environment. I think we can walk patients, but we often don't quantify how far they've walked, how fast they've walked, what the heart rate might have been at the start of that walk, what it is at the end. So I think, again, seeing every kind of therapeutic intervention as an opportunity to, you know, measure and promote aerobic condition and also strength performance as well. So if you're seeing someone on a ward, you could look at repeated sit to stand. So how many times can they sit to stand in 1 minute? That'll certainly give some insight into both aerobic condition and lower limb strength. But then you could also look at their walking. So maybe, integrate the 6-minute walk test as part of everyday therapeutic activity. But then also, as I say, where appropriate, using either free weights or a kettlebell. Kettlebells are probably better than dumbbells for a lot of patients, particularly if they have got unilateral changes, so that they can look at how many times they can repeat a particular technique, so that again, we're quantifying what we're doing, we're measuring change. It's a much more motivating experience for the patients. But I think also in terms of our role as physiotherapists, I think we're using the skills and expertise that we've got, which in terms of looking at just general mobility, I think we need to question really.
Yeah,
Yeah.
absolutely. That's great. And so, I'm a bit of a techie, so I'm just going to ask you, is there any, can technology assist us in this at all? Even
Oh,
from like pedometers to, I don't know, technologies from pedometers to robotics, what can we use to help us? Or is it appropriate?
absolutely, and I think certainly the research that I recently did, one of the questions that we asked the participants was, would you be happy to have your physical activity monitors levels monitored using something like a pedometer or an app on a smartphone? And there was only one client or participant who was a bit hesitant about it. The remaining 7 people were all quite happy to have their physical activity levels monitored. So things like Fitbits, things like apps on phones can, sort of give us quite a lot of detail about distance covered in a day, number of steps taken. And I think that's really important that we're looking at long-term physical activity levels. But then there's also the things like the apps like Map My Walk, and that can, sort of generate camaraderie with other people who might be using the same app, so you can see how far someone's gone and comment on it and things. So yeah, I think there's a lot that can be, done, and I think a lot of the population, including the older population, will really engage with that if they're given the support. I think, there's an increasing number of people who've got smartphones now, and there's so many apps that can be added to them, which would give us quite interesting data, I think, that would, I think, motivate the patients to be more active, but also give us an insight into how active they are as well.
How active they actually are instead of what they're telling us.
Absolutely, yeah, as long as they're not sort of just attaching it to the dog and
Yeah.
throwing a ball for the dog. But yeah, I think all of that, and I think also a slightly unrelated topic, but there's also more accessible exercise equipment out there as well now. So I talked about the regular gym environment, but I think there is a growing market for sort of more purpose-built exercise equipment. So I work with a company that develops power-assisted exercise machines. And again, for people who struggle to initiate movement, and that sort of goes for a lot of the neurological population, it's a really good opportunity to both stretch, strengthen, improve aerobic performance, but I think also importantly, get out of the house and again sort of mix with peer groups and hopefully have something that's enjoyable without being too intimidating as well. So certainly with the power assisted equipment, we've done a couple of feasibility studies with patients with long-term neurological conditions, and the early output from that has been very positive, that the patients have enjoyed it and they've reported feeling better for having used the equipment. So there's a couple of studies, larger scale studies, that are in the planning stages at the minute to I think more accurately measure the impact of using these machines with particularly people with more moderate to severe motor impairments as a result of a neurological condition as well.
Yeah. It's great to hear you talk about all this physical activity, increasing this in individuals with neurological conditions and long-term conditions, because it just feels right. It just feels right to talk about it and to be encouraging this in our patients. So yeah, it's really good to hear you talk about it all. I'm aware of the time and how much time you've got. So is there? I think it's quite a nice place to end. We've talked a lot about the physical activity and all the skills that people need just to treat individuals with neurological conditions. Is there anything else that I haven't asked you about that you think we should perhaps talk about or that you'd like to mention?
Um, no, I feel like I've probably shared a lot of my current thinking. I think absolutely there's a lot of evidence that's coming out now related to exercise and physical activity in long-term conditions. I think also, the public health crisis almost that we're facing in terms of, increased proportions of people being sedentary and all of the sort of negative effects of that. And as physios, I think it's very important that we're aware of the current evidence, we're aware of what types of techniques might be most effective, but are always thinking about not just how someone moves, but how much someone moves. as well. So yeah.
That's a really good thing to end on, not just how someone moves, but how much they move as well. I like that. It's good.
Yeah.
Yeah. So
Good.
is there anywhere we can find out about your work, Rachel?
At the moment, probably not. I'm due to start a PhD in September, and that's going to focus on the use of power-assisted exercise for people with moderate to severe motor impairments with MS. So I'm, obviously looking at publishing as I go along, actually, the PhD route that I'm choosing. So, watch this space. But right now, I've nothing that I can directly send you to. But I think a lot of the topics that we've covered today. Certainly, if you go into most databases, you would find the research that's currently being published in relation to that as well.
Okay, I think we'll look up some of that to share as well. And are you on Twitter?
I am, yes. It's Physio Young.
Physio Young on Twitter.
Yeah.
So if you have any questions for Rachel, you can bombard her on Twitter. She might answer, she might not.
I'll do my best. Yeah, no, I'd like that. I'd really love to hear from the people who are working on the course as well. That'd be great.
Yeah, okay. So we'll add your Twitter handle and we'll talk to you there. So Rachel, it's been an absolute pleasure to speak to you today. Thank you so much for sharing your knowledge. It's been great.
Thank you very much. Thank you.